A little bit of the work I'm getting into now, which I think speaks to this point, is more machine learning, which I'm not sure how much of you are familiar with that, but it's basically these statistical methods where you're trying to predict something, let's say suicide, and the way you do that is you enter a lot of data, a lot of variables, basically everything you have into a model, and you let the data tell you what the most important predictors of that outcome are. And so this is a very data-driven, I'm basically taking everything from the registries, I'm entering them in to see what predicts suicide. It's particularly good in situations like suicide where we have had decades of research on it, and yet we are very, very poor at predicting it clinically. We really don't know why certain people go on to die by suicide and others don't.
Dr. Jaimie Gradus is an epidemiologist at the Women's Health Sciences Division of the National Center for PTSD and an assistant professor of psychiatry and epidemiology at Boston University's School of Medicine and School of Public Health. She received her BA in psychology from Stony Brook University and then her MPH with a concentration in epidemiology and biostatistics, and a DSc in epidemiology in Boston University. For those of you who don't know who a DSc is, because I had to Google it today, it's a doctorate of science. It's like kind of the same thing as a PhD, but basically more fancy. Dr. Gradus' research interests are in the epidemiology of trauma and trauma-related disorders, with a particular focus on suicide outcomes. She was the winner of the 2009 Lilienfeld Prize from the Society for Epidemiological Research for a paper on the association between PTSD and death and suicide from the population of Denmark. Dr. Gradus has been the recipient of multiple National Institute of Mental Health and Foundation grants to conduct epidemiological research in both veterans and the general population. And without further ado, go ahead.
Thank you, Daryl, for such a nice introduction. And thank you, everyone, so much for being here today on this beautiful evening of warm weather. Being inside to come hear this talk. As Daryl said, I would love for this to be sort of more of a discussion to answer any questions you have, so please feel free to interrupt me at any time. If you're online watching this live, please feel free to answer or enter any questions. And yeah, so with that, I'll just get started. So today I'm going to be talking a little bit about my journey into becoming a psychiatric epidemiologist, which I will be the first to admit is sort of a weird thing to be. There are not that many of us, so I'll tell you how I ended up here. And then I'll also be telling you a little bit about the work I've done in Denmark, both my specific studies, but also a bit about why it's useful to have population-level data for research purposes and how Denmark sort of ended up with that data. So what is psychiatric epidemiology? For anyone that didn't get to Google something before they came here tonight. So epidemiology is the study of diseases in populations, basically. It's the study of why certain people get the diseases they get and what risk factors essentially are contributing to that disease onset. And it's basically about populations. The idea is that if we study enough people, we will find patterns of disease occurrence in populations, ultimately. So that is epidemiology, and psychiatric epidemiology is the branch within epidemiology that deals with psychiatric disorders within populations. So why do certain people get psychiatric disorders and others don't if they seemingly have the exact same risk factors? So how did I find this unusual career? A little bit of a history lesson about me. It actually started across the street from here, funny enough. I was living on Boylston Street, right across from the Lenox Hotel, when I was at first working at Mass General Hospital on this gigantic bipolar disorder study. And I had come from New York, where I went to Stony Brook University, as Daryl mentioned, and I was a psychology major. But after my time at Stony Brook, I really didn't want to do clinical work. I wasn't sure what I wanted to do, but for a variety of reasons, I felt like clinical psychiatry was not, or clinical psychology was not the path for me, and psychiatry was not the path for me either. So I ended up kind of not going to grad school straight out of undergrad and moving to Boston to work on this study at Mass General Hospital. And the study was this 5,000 person national bipolar disorder study, which for any of you that know psychology or psychiatry research, is pretty big by those standards and is around the same size, if not on the small end of what we might have for an epidemiology study. And so in the course of my time working on that study, I started to hear epidemiology get thrown around a lot as a term, and sort of public health and a naturalistic study. And it was something back in those days, probably 20 years ago, now it was 20 years ago that I was at Stony Brook, really you didn't hear a lot about in undergrad, even at Stony Brook, which is a school that's sort of known for its medical training. So I ended up deciding to take some classes to figure out what epidemiology was. What were all these terms I was hearing on this large bipolar disorder study I was working on? And Harvard Extension School at the time had a certificate in public health. And so it was there as part of that certificate that I took my first epidemiology class. And it was such a key moment in my life. I walked into the room on the first day and I sat through the first lesson and I was like, this is exactly what I want to do. Like, it just hit me, it was done, I was in, I loved it. I loved everything about it. It's basically research methods. You can apply them to the study of pretty much anything. Cancer epidemiology is a huge field, cardiovascular epidemiology, of course, infectious disease epidemiology is probably what you know most well from movies and TV and things. But I was hooked. So I applied to a master's program at Boston University in epidemiology and biostatistics. That's a prerequisite for epidemiology doctorates, is having an existing higher level degree. And I completed that degree, and then I ended up in the doctoral program also at Boston University. And then I did my coursework, and it sort of became time to think about doing a dissertation. And that is how I ended up here. So this is a picture of me outside of Legoland. This is actually the original real Legoland in Billund, Denmark, where Legos were invented, and the airport I happen to fly into every time I go there. So the way in my BU doctoral program I ended up here in Billund, Denmark, was that I was looking for data to use for my dissertation. I knew I wanted to do something on suicide, predicting suicide, but something that you may or may not know, depending on how much you know about suicide, is that it's actually, for everything you hear in the media, a pretty rare event. Suicide is actually pretty hard to study because it doesn't really happen that often. And I'll talk a little bit about the consequences of that when it comes to research. But so I was interested in doing suicide prediction work for my dissertation, and I had a mentor at the time who's still a great mentor of mine who said, there's a group of us working with these Danish national registries. We want to bring students into that collaboration. Would you be interested in being one of them? And I said, sure. So there I ended up in Denmark to do my dissertation, and I've continued a career there ever since. So let's talk a little bit about why Denmark before we delve further into the actual research findings. So Denmark is here on this is a map of Europe, and you can see it sort of highlighted in a little bit of a darker blue than the rest. It's in Northern Europe. Aarhus is where I go 3 times a year for the last 10 years to do this research. It is the second biggest city in Denmark. It's a college town, kind of like Boston. They have a major university there. That's why they have the clinical epidemiology department I collaborate with there. And Denmark has got universal, tax-funded, income-independent healthcare. So basically, every Dane gets free healthcare. And as a consequence of this, they have extensive long-term record keeping on the care that people receive. So you can almost sort of think of it like a big billing system. The government pays for everybody's care. So when someone gets care, the doctor bills the government keeps track of it, and now they have records for decades and decades and decades on all the care everyone's received. You can also link between all of these records individuals' data from one registry to another via something called the central person number, which is essentially like a Danish social security number. And they have lifetime follow-up. So they know if someone emigrates, they know if somebody dies, but essentially if you are still living in Denmark, they know what's happening to you healthcare-wise for your entire life. One thing that I always point out about these data, that actually a criticism that people give me, is that, really at the end of the day, it's healthcare use data, right? So if somebody isn't going for care, then they won't end up in those registries. If somebody is avoiding maybe dealing with the issue they have, which is common with some psychiatric diagnoses, they won't be in my registry at all. And I highlight this. It turns out when healthcare is free, people tend to use it. So this is in the top, the total population of Denmark in 2016, and the total number of people that sought, I think, at least one visit of general medical treatment. And you can see those numbers are strikingly close. So it turns out that the registries do have pretty good coverage of almost everybody in the population. You kind of have to assume within that if something were severe enough, if a psychiatric disorder were severe enough, it would get spotted on one of these general treatment visits, but still, pretty much everybody is making contact with the healthcare system in a given year. So the Danish civil registration system is really the cornerstone of all of this. It's been in existence since 1968. It's updated daily, and it basically is a register of everybody who lives in Denmark. It's got birth and death dates, marital status, immigration status, resident information, and it of course contains the unique identifier, the CPR number. And so there have been many papers published about using these Danish registries as a tool in epidemiology. This is a breakdown, oh sorry, my pointer doesn't work, but this is a breakdown of the CPR number for each person, what it contains, date of birth, sex, and a serial number. And today there are over 200 medical and administrative Danish registries that can be linked together to study population level occurrence of diseases. So there's a cancer registry, there's a cause of death registry, the civil registration system I mentioned is sort of the backbone of all of it. The Danish National Patient Registry includes every physical health doctor a person has ever seen. There's the Psychiatric Registry, which is not on here, which includes all encounters with psychiatrists and psychologists. And you can see a few others listed as examples. And so this has led to the Danish data being called the epidemiologist stream, right? The epidemiologist's job or our goal is to study the occurrence of disease in populations. And so to have actually a population full of data is sort of a unique thing and really something that's a very, very amazing resource to epidemiologists. So in my career, I used the Danish registry data to study outcomes of PTSD and other stress disorders, primarily, as Daryl said, with a particular focus on suicide. Does everybody know what post-traumatic stress disorder is? Yeah, you know. Or you have a question? Oh, yeah, wow. Yeah, so everybody, I have the definition here. I don't want to necessarily read it, but post-traumatic stress disorder is something that people experience following a significant traumatic event from which the person is having a hard time recovering. There's research that shows that most people actually will experience symptoms consistent with PTSD in the immediate aftermath of a trauma, but then usually those symptoms will abate with time. For people for whom the symptoms don't abate with time, they might end up with a diagnosis of PTSD. So why is it important to study outcomes of PTSD in a full population sample with existing data? Well, there are a few reasons I would suggest to you. The first is that outcomes can be rare. So I mentioned this earlier about suicide. On the population level, suicide is actually pretty rare. It doesn't happen that often. So you need a lot of people to study it. You need many, many, many people. And one thing that you quickly will bump up against when you need a lot of people to study something is money. Getting the money to get a lot of people to study something and the time. So having a resource like this where you have many, many people with already collected data can help you study something that's rare in a very efficient way that costs less money than it would if you had to actually go out into the population and find all of these people. The other reason that it's important to study PTSD outcomes in a full population with existing data is that some outcomes take a long time to happen. And again, in that situation, you're bumping up against this practical issue of needing somebody to fund you sitting around waiting for outcomes to happen in a lot of people. You know, one kind of classic example of this in epidemiology is smoking and lung cancer. Epidemiology studies are the ones that have documented an association there, but it takes a very, very long time for lung cancer to develop. So if you were a researcher who had to follow a group of smokers from the day they started smoking until the day they got lung cancer, you would need a lot of money and a lot of time to keep that study going. So it becomes impractical to really do in a sort of primary data collection setting. And then finally, there are some outcomes where it's hard to really get accurate data once the outcome has happened. You know, an obvious example of this is suicide, where there's a lot of work that goes into, for example, in psychiatric autopsy studies or psychological autopsy studies, going into recreating what was happening with the person prior to the suicide. But you can kind of say this about any event in someone's life, practically, right? Once an event happens to you, let's say you've experienced a trauma, sort of your life before the trauma might be remembered differently by you than your life after the trauma. The trauma changes the way you remember your life prior to that event happening, in some cases. And so it can be hard to get really accurate data once events have happened. So having these Danish registries where you have a lot of people recorded, prospectively, the data is added as it happens, over decades and decades and decades is a tremendous resource in being able to study some of these psychiatric problems that would be otherwise very hard to study on the population level. So I'll talk a little bit about one, it's actually across a few studies, but it's one overall study that I've done looking at outcomes of PTSD in Denmark. So in this study, we had 4,029 Danish people diagnosed with PTSD sometime between 1995 and 2011. Some of them were children, but most of them were adults. And we took a sample of 20,145 people who never had PTSD, but they were the same age and the same gender as one of our PTSD people. We matched them, and we took their data too. That's our comparison group. 60% of the sample was women. That's very consistent with what you'd see in the US, where people with PTSD women tend to outnumber men. We used the psychiatric registry to identify the PTSD patients. We took the comparison group members from the civil registration system. And of course, we linked the data with other registries to be able to examine outcomes. So the first thing I'll present tonight is PTSD and cancer. This has been something that people have talked about for decades and decades and decades in the scientific literature, really 70 years, if not more. Stress and cancer. Stress causes cancer. You might have even seen this somewhere in your life. And so we thought, well, we have an opportunity here to look in a population-based sample at whether or not people diagnosed with PTSD are at an increased risk of getting cancer than people who've never been diagnosed with PTSD. And because we had large enough numbers to do it, we can kind of look across different types of cancer. And so I'll tell you what we found is essentially nothing. So let me just go through the first row and explain to you what we saw. There were 159 cases of cancer observed among people with PTSD. Based on the general population cancer rate at the same time period, we would have expected 154 cases. And that gave us an estimate of 1.0. An estimate of 1.0 essentially means there's really no difference between your two groups. It really means the people with PTSD had cancer at the exact same rate that the people without PTSD got cancer. And we looked sort of across all these different types of cancers and really found no strong evidence of an association anywhere. So until this point, this had really been only examined for specific stressful events or for only one type of cancer because, again, to get a large sample of people with lots of different types of cancer is very challenging. So this was the first study that really looked at PTSD and different types of cancer in one sample and found no evidence of an association. Next, I looked at PTSD and cardiovascular disease events. This is really talked about a lot, especially in the veteran literature. There's a lot of United States veteran work on PTSD and cardiovascular disease showing an association. Again, it had not been done in a general population-based sample. And so basically I found that there was a slightly increased risk, actually, of different cardiovascular disease events if you had post-traumatic stress disorder compared to the general population. So it looks like about 1.5 times the risk of a heart attack if you have PTSD, 1.7 times the risk of stroke, 2 times the risk of venous thromboembolism, and really no evidence of gender differences. That was sort of an open question in the literature at the time. Are there differences between men and women on this? But we didn't find much evidence of that. Gastrointestinal disorder is very similar, has been talked about in the literature for a very, very long time. A lot of studies group gastrointestinal disorders together. Again, I think this is sort of a consequence of having to collect data on people, you know, having limited resources, and ultimately deciding that to get the statistical numbers you need, you have to put all the people with gastrointestinal disorders into one category, even though those disorders differ. And so there's some controversy in this literature at the time this paper was published because some studies found an association between PTSD and gastrointestinal disorders and others didn't. Others said, we don't find anything here. And sure enough, we found different associations depending on the type of gastrointestinal disorder you're talking about. So if you look kind of 3/4 of the way down at diverticula of the intestines, you see an SIR again of 1.1 that's basically suggestive of no association between PTSD and diverticula of the intestines. But if you look at peptic ulcer, site unspecified, about midway through the table, you see an effect of 3.3, which means people with PTSD had 3 times the risk of peptic ulcer. So no association there. So this paper went to show that in these studies where people have been forced to sort of group gastrointestinal disorders together because of sample size issues, that might explain a lot of the reason that people found different associations. Yes?
So what sample size do you think would be at the lower limit that you could be confident with your data?
So the question is, what sample size would be a lower limit so that you would be confident in your data? So as an epidemiologist, I'm going to say like the biggest sample you could ever get. There are other people that deal in sort of working with smaller samples that might have a better answer to that. There are certainly calculations you could do, like power calculations.
Because your tightest correlation is for your smallest sample.
Right, for the peptic ulcer is the smallest sample, yeah, which is interesting too. Yeah, that's a good point, actually. I hadn't noticed that before, but right. So yeah. And then finally, I was very interested in looking at mortality, PTSD and mortality. As we talked about before, suicide is a particular area of interest of mine. We found that people with PTSD had 2 times the rate of all-cause mortality than people who had never been diagnosed with PTSD. And this adjusted for physical health problems they had. This adjusted for other psychiatric disorders they had been diagnosed with. So there's something happening with PTSD that's increasing risk for mortality overall that isn't found in the general population. And then with suicide, we found an incredibly high increased rate among people with PTSD, which is probably no surprise to anyone that follows the news on this or the literature on this. So I'm going to wrap up close to my 25-minute time mark with some issues for us all to consider, and I'm happy to talk about any of these further in the remaining question and answer time. When I talk about sort of the limitations of this work and the strengths of this work, I think about it according to differences in people. So one question we could ask about this study is, do we believe that disease etiology is really the same across all people? This is sort of the basic idea here, that we are really generalizing back to etiology. We're trying to discover an underlying association between 2 disorders that we believe in theory should be the same across all people, but how much we trust in that will really dictate how well we believe this work might generalize back to what we know here in the US. Place. So do we believe that results from another country can be applied to people living in the US? And what if we can't do this work in the US? Like, we can't. Is it still worth to do it in Denmark and take the risk that perhaps we're finding results that may be similar to what we would know here in the US, but not exactly the same? This is all reasonable questions. And then finally, time. Whenever people kind of bring up to me this issue of, well, we don't know that what you find in Denmark is going to be the same as you would find here in the US. What I say to that is, we also don't know if what we find here in the US is going to be the same as what the US population of 20 years from now is going to experience, right? We're changing on all 3 dimensions, people, place, and time. So, to say that the work may be limited by generalizability is a fair point, but also we have to consider that when we're thinking about research that's going on today, even in the US. And just sort of anecdotally, when I hear or talk to people about why research reports in the media always differ so much, these are some of the things I think about, All of these things affect the results of any study, and that some of that will ultimately get picked up by the media and, become things that you hear, And so when we hear conflicting reports in the media about research results, it is likely true that 2 studies have found different things, and it could be for any of these reasons among many others. So I think with that, I will leave it there, and I'm happy to take any questions.
So, yeah, I noticed your data was collected from 1995 to 2011.
Yeah.
And, I don't know, I'm not a doctor or anything, but I do know that a lot of times that diagnoses for these diseases are constantly being developed, and I would expect that 2011 would have more accurate diagnosis for these problems than, say, 1995. So did you notice, was there any part of your data that you said, well, we need to kind of understand the fact that these things are changing over time, do you have to do it, or I don't know, can you just speak to that? Like, is that considered, or is that something that you...
Yeah, that's a great question. This is a great question about the change in psychiatric diagnosis over time, which absolutely happens. I don't know how many of you are familiar with the DSM, or the Diagnostic and Statistical Manual for Mental Disorders here in the US, now on its 5th edition, so over decades it has changed and diagnostic criteria has changed. In Denmark, they use the ICD, which is the International Classification of Diseases, and so disorder sort of symptom profiles do evolve over time. it's not as quick as you might think it is. So the reason the study started in 1995 is, there were two reasons actually. One is that Denmark went from ICD-8 to ICD-10 in 1994. And we really wanted to capture new onset cases of these disorders. So we figured once they switched over to ICD-10, there would probably be a year where anybody who had the disorder previously but had been diagnosed with something else under the old system would now be re-diagnosed with the stress disorder or PTSD. And so starting in 1995, we felt a little bit more confident that we would have new onset PTSD cases at that point. The other reason is the psychiatric registry I mentioned began including outpatient visits as well, outpatient treatment in 1995. So with disorders like PTSD, where I think the inpatient stays would be the minority, we wanted to definitely capture outpatient disorders. All that said, Denmark is still to this day using ICD-10. So it's 2018, so it's been 23 years of ICD-10 in Denmark, and that is not rare. ICD-11 actually just came out a couple of years ago. And so, in these big systems, it takes a little bit of while for something like that to be implemented, but that is something that we will have to consider going forward as it changes.
But you were correlating the PTSD. You are also correlating the PTSD to other certain things which like the ulcer, or there's other gastrointestinal disorders, which I know, in that many time, there's a lot of different differentiation of gastrointestinal disorders based on, in autoimmune diseases and all those other things that we're learning about those. So those diagnoses would also probably be affected.
Yeah, it's possible it could be. Everything from 1994 on in the Danish registries was based solely in ICD-10. So none of them really changed that much over that period of time, but it is something we'll have to grapple with going forward for sure, especially when ICD-11 gets implemented.
Great.
So you explained about why you choose Denmark, because they have, really comprehensive data and etc. And also you bring up the question whether they are applicable to, other countries, etc. So what do you see the, moving forward for countries that do not have as comprehensive as, systematic data? What would be the way moving forward if you wanted to study, the epidemiology in those countries?
That work happens, and that there's some very amazing long-term research that has been going on here in the United States, looking at psychiatric epidemiological samples, primarily ones that were collected via survey or via clinician interview. We don't have much in the way of registry-based data like Denmark does here in the US. We have the VA, which is one system, and I also am a VA employee that has registry-based medical records on everybody in its care. The trick about the VA is there's actually no crosswalk between VA and DoD data. So Department of Defense, people are there first, they leave the Department of Defense, they go to the VA. Us in the VA had no way to know what happened to them during their time in the Department of Defense. Of course, there's also no registry-based records on their life before they even went to the military, which would be ideal. So there's certainly a ton of very well done, sophisticated psych epi research that goes on here in the US. It just doesn't have quite the breadth that this has because this is somebody's whole life documented basically. And in the US we have really no way to get at that in as large of numbers as they can do it in Denmark with the registries.
I'm curious about some specific ways that Denmark psychiatric data has informed the design of different behavioral treatments.
Mm-hmm. So that's an excellent question. And since I'm not on the treatment side of things per se as a scientist, I don't know much about sort of the research that's come out of Denmark that has informed behavioral treatments. I would say, as I mentioned before, I think that the VA is probably at the forefront of treatments, particularly around PTSD. We know there are some forms of therapy that work very effectively for PTSD. Some of that work has been done at the VA, a bulk of that work. Other of that work has been done by some researchers I know. Patricia Resick is one of them, who did a lot of work developing a therapy called cognitive processing therapy that the VA has rolled out nationwide for treatment of PTSD. So there are some good treatments for PTSD that work. I would say that they are not the result, though, of this epidemiologic research on PTSD, but more the result of psychology research, actually, that's gone on here in the US.
You have mentioned that the risk for those people that have the PTSD is higher to get. gastrointestinal disease. And I'm wondering that, I'm just curious if you know about the molecular and cell biology based,
I'm sorry,
what
say
would
that
be
again?
on the molecular and cell biology aspects.
Louder again.
On molecular and cell biology aspects, what
Okay.
would be the reason that they have the higher risk of getting gastrointestinal
Yeah, so inflammation
disease?
is the big pathway that people tend to talk about in this area. And, I'm not a biologist or, a person that deals with sort of the mechanisms of the underlying biology of these things. But inflammation is a pathway that people commonly talk about when it comes to stress response and gastrointestinal disorders. Frankly, with a lot of the physical health consequences of PTSD, that's something that's often mentioned.
I was struck by how granular the data was for the patients, the fact that they were able to delineate between different gastrointestinal diseases and conditions. And I was wondering, what is their method for capturing that data? Have they sort of transitioned to a completely electronic medical EMR system that allows them to track everything all around the country? How is that set up over there?
That's a great question. It's entered electronically, but there are medical notes too, actually, so regular chart notes that somebody might write that are sometimes still kept in paper format in charts. The way that I know this is that I've also done a validation study of the stress disorder diagnoses in Denmark, where my wonderful project coordinator actually went to the clinics and read people's physical paper chart notes to determine if the stress diagnosis that was recorded electronically in the register was actually consistent with the symptoms they were endorsing experiencing. But yeah, that is all done electronically as far as entering the codes go.
So I don't come from a biology background, but my question is, so the aim of your study is basically to be able to prevent PTSD or diseases that come after PTSD from happening, right? Mm-hmm. And so what is the way to do that? For example, for gastro problems, you said that you found a relation in between that. So what your work would suggest then to treat people directly after their PTSD, or what is the method to do that?
Certainly for clinicians to be aware that it might be a problem that is subsequent to PTSD, that and then they might be able to detect the symptoms. They might be able to detect the symptoms earlier or know what to look for earlier when symptoms begin to occur. So I also don't work sort of in gastrointestinal intervention of any sort. But the idea would be that if clinicians can be aware of what to look for subsequent to these diagnoses, then maybe they'd be more prepared to treat things early when they occur, when it tends to be easier to treat them than later.
Hi, so I know that someone asked a related question about the significance statistically, and I was wondering if you'd done statistical models or to figure out the statistical significance of some of your findings?
Yeah, so epidemiology, you've touched on a controversial issue. Epidemiologists, especially where I've trained, really do not believe in statistical significance testing. The reason for that is because statistical significance is dependent on the size of the effect and the size of the sample, right? So if you have a sample that's gigantic, all of your effects will be statistically significant, as is often the case in my Danish studies. Everything I find is basically statistically significant. You could also have the most important effect anyone's ever found between two things, and if your sample isn't big enough, it might not be statistically significant. So in my work, I tend to shy away from using statistical significance to determine if associations are important. I use the size of the effect. I sort of use what I know about the state of that literature and what seems like, it is consistent perhaps with what has been found in other samples, but I don't use statistical significance per se to determine if relationships are important. And actually here it's sort of impossible to do.
So just thinking, because you mentioned about, statistical significance. So during your research, how much do you, because there is intuition and there is data. So how do you combine the two?
Say what the first word you said was.
Intuition, like the domain expert,
Yeah.
because, for certain things you understand the physics or the mechanism or biology behind it. So you identify that as, a risk factor or could be a correlation. So how do you balance that two between the intuition and the data?
So the question is, how do I balance between my intuition of what I think is associated basically in the data? I mean, I trust the data, So for example, there was reason to believe that stress and cancer might be associated, right? That's something that people have talked about for a very long time. But I found an effect that it was basically null. And so I didn't need, anything to tell me that even though I believe that that may be associated, the effect is not there. A little bit of the work I'm getting into now, which I think speaks to this point, is more machine learning, which I'm not sure how much of you are familiar with that, but it's basically these statistical methods where you're trying to predict something, let's say suicide, and the way you do that is you enter a lot of data, a lot of variables, basically everything you have into a model, and you let the data tell you what the most important predictors of that outcome are. And so this is a very data-driven, I'm basically taking everything from the registries, I'm entering them in to see what predicts suicide. It's particularly good in situations like suicide where we have had decades of research on it, and yet we are very, very poor at predicting it clinically. We really don't know why certain people go on to die by suicide and others don't. So kind of getting back to square one and saying, let's put all these predictors in this model and see what the data tells us are the strongest predictor of suicide is one way I'm headed in my research. So I hope that sort of answers that question. But
so bringing the news into this a little bit, and the fact that there's a lot of conversation around the last shooting that happened, and how much some people want more research and more data in order to be predictive of those kinds of events, which are also sort of related to I'm sure the PTSD and things that you study. Do you have a wish list if that were suddenly opened up?
Yeah, so I am on a few projects that people are currently trying to get funded to look at some gun ownership beliefs, gun violence prevention work. I know some people that are doing a lot of great work in this area. One at Northeastern, there are a couple of people at Harvard that do really good work in this area. It has become a little bit challenging to get gun research funded in the US. Which may not surprise most of the people here. So that is a barrier there. But I do know people that are working really hard on that topic. And I wouldn't say that I am per se a gun violence researcher, so I don't necessarily have a wish list of things that I would study related to gun violence per se. But I agree, it's critically important.
Another question. So do you feel that it's harder to present your data to the academic community when there aren't as many as much research about the statistic significance of it?
No, I haven't really encountered that at all. Mostly because I think people understand that given the sample sizes, it's not going to be that useful of information. There was one time, long ago, when I was still a doctoral student, I was presenting a poster somewhere at a conference that was sort of mixed discipline, and somebody said to me, well, how do you know what's important if you don't have statistical significance? Which is a question that hurt me a little bit, given the way that I was trained. But no, since that was really the only time I could think of in the last 20 years that really anybody said anything to me about it. And since I've presented at many sort of multidisciplinary conferences, I do attend a lot of epidemiology conferences where it's not that unusual to people. But I also present at multidisciplinary stuff where it doesn't really come up.
Well, thank you so much for joining us today.
Thank you, everyone. This was a lot of fun.
Thank you, everyone, for being here.